And so Guillermo, if you'll take down your slide, she'll slide share hers, and we'll go forward.
All right, am I taking over?
Yes, you are.
Let me put my screen. Oops, I don't know if they can see that.
Yeah, it's perfect.
So why did I lose everyone? So I just see myself on the corner. Uh, let me see, sorry.
Because you're just in speaker mode, so everyone
Oh,
just
so I'll
you
just see
and your
myself?
slide.
Okay, so I'll be just seeing myself.
Yeah.
I don't see anybody else. Okay, good. Although I want to interact with them. But anyway, so I'm Maria Elena Stead. I'm a certified diabetes educator. I've been at Eisenhower for a little over 12 years, 11 years in the diabetes department. So I'm the manager of the department now and one of the diabetes educators. I just completed my master's degree in nursing with a specialization in diabetes a couple years ago. And I have a bachelor's degree in nursing also. So I am very passionate about diabetes. I don't have diabetes yet. But someone asked me if I have it, I said not yet, but I do have high risk because it runs on both sides of the family. So I am very open to helping anyone that needs help or wants my help. And so I would like to make sure that you, if you have a question, unmute your phone, your microphone and ask the question, or you can wait till the end and see if I answer the questions on my presentation. But I wanted to be more interactive, make sure that I'm helping you. So this is our phone number for our department. If you ever need any question, have any questions or need any help, and then you have my email that you're welcome to email me with any questions. So today we're talking about basics in diabetes, the myths and nutrition. So I'm sure you have heard about several myths, and this one is a little list that we're going to go through, and I'll answer them through the presentation. But these are very common that I hear all the time. People with diabetes cannot eat any sugar, right? They're done. They're already too sweet, so no more sugar for them. So we'll clarify all this. Type 2 diabetes is mild. Type 2 diabetes only affects people that are overweight or obese. People with diabetes should only eat diabetic foods, and they go blind and lose their legs, and they're dangerous drivers. Well, I don't have diabetes, but I could be a dangerous driver. So I don't know about that one. Um, so there is this formula here that you cannot really, I can't see it because on the top is covering part of it, but the CDC states and the research that 1 out of 3 people will have diabetes by 2050 if we don't change the trends about stopping or preventing diabetes. So they'll get diagnosed with type 2 diabetes 1 out of 3, and 1 out of 5 by 2030, which is only 10 years from here, 10 years away. So that's very fast growing epidemic. It's worldwide, it's not just the US. We just received our latest statistics in the US, and we went from 30 million people with diabetes in the US to 34 million. And for pre-diabetes, we went from 84 million to 88 million, just in the United States. In the country, someone is there, it's very expensive to have diabetes. This a statistic, this slide is only for California. So we spend a lot of money in California for diabetes management. So it's a fast growing epidemic. It's expensive to have diabetes. So if you can prevent it, it will be a lot easier than to manage it. There is a real struggle right now for people to afford their medication, especially insulin if they need insulin. So the burden of California is the diagnosis that costs to the state $39.5 billion every year. And this is a very serious complications that include the disease, the heart amputations, and stage kidney failure, basically, and death. So a lot of the money that is raised in California and tax goes to diabetes management. So those complications can be prevented. So we're going to talk about a little bit on what can you do to prevent all this. So we'll start by talking about what causes diabetes and what are the risks for this disease. And if you look at this slide and you look at the list, see if you can see how many of those you have that can increase the risk for you for diabetes. One of those is the history of having that elevated blood, we call it blood glucose, or it's blood sugar, it's the same thing. People that have elevated sugars or glucose, pre-diabetes, have higher risk for type 2 diabetes, obviously. And they do have the opportunity to make some changes and prevent type 2 diabetes. If they don't change anything, then they can advance to type 2 diabetes very quickly. Overweight or obesity, so people have that option of changing their lifestyle and getting back to their normal weight. And physical inactivity. One of the myths that was on the first slide, that obesity, everyone that is obese can get diabetes, is not true. There are a lot of people that are obese and they don't get diabetes. They're very healthy. They're just overweight, but they can work on their weight loss and they never get diabetes. Physical inactivity is a risk if you're not physically active. If it runs in your family history, then you cannot change that. It increases the risk as long as it's in your family. Ethnicity, races for Hispanics, African Americans, Asian Americans, Pacific Islanders have higher risk for type 2 diabetes. Although in the area where we are, most of our patients are Caucasian. So that depends on the demographics of where we are. We do see some Hispanics, some a few African Americans, few Asian Americans, but not that many. Age is always a risk. If you're over 40, 45 years old, then that could increase the risk for getting diabetes if you have high blood pressure and high cholesterol. So we are trying to cover here glucose control, blood pressure, and cholesterol. So we'll go over those things. And so what is diabetes? Diabetes is a condition of the pancreas, which is our organ that is behind the stomach. It's a very tiny organ that is releasing many hormones. And one of those that are very important is insulin. But when the pancreas gets damaged, it could start releasing less insulin, or it could be that insulin is just not working well. So we need that insulin to keep our sugar more under control, more level. And if we're producing less insulin, then our sugar is going to go up. But if what we're producing is not working, that glucose eventually is going to show up when you go to the lab. And we want to catch that early so that you can start the treatment early, or diabetes education early, and start making some changes. So this has nothing to do with a person being their fault, that is their fault they got diabetes. This has to do with their pancreas. How is it malfunctioning? And then people being aware that their sugar is going up and get it started with the treatment. The studies they have, and they probably changed already, but I like this cell, is that by the time a person gets diagnosed with diabetes, they lost about 50% of their beta cells. Although I was reading a study from Dr. DiFronzo, and he says that they probably lost about 90% of the cells that produce insulin at the time they get diagnosed. And so they also say that by the time you got diagnosed with diabetes, you probably already had it for at least 5 to 7 years, and you did not even know that. And this is very important for you to go to the doctor, to regular appointments, go to the lab, to keep an eye on your fasting glucose, just to see that everything is still normal. So these cells here, they're called the beta cells. You see that we have a lot of different cells, but the beta cells are the ones that are in charge of producing the insulin. And our pancreas is releasing insulin 24 hours continuously to help us keep our sugar controlled. And so if we're releasing less, we're running out of those beta cells, we're using them too fast, then obviously our sugar is going to go up, and hopefully we get a diagnosis of diabetes or pre-diabetes, and then start changing something on our lifestyle or taking medications and getting educated for that. So diabetes is not a disease that once you get it, it's going to go away. You can work to put it in remission. You can calm it down, get your numbers back to normal, and just try to keep it there the best you can as long as you can. but it's not going to go away. And that's what I always clarify for our patients, that their goal when they come in is to get rid of diabetes. I hear a lot of doctors giving lectures saying that they can reverse diabetes. It's not completely been reversed. It's been put in remission. If you stop making the changes that you're making to keep your sugar control, that's going to go up again. The medication, the treatments are going to increase. So it gets complicated. It's a chronic progressive disease, but it doesn't have to be. It doesn't have to progress as fast if you're making some changes on your lifestyle and taking your medications, checking your sugar. So we'll talk through this whole presentation about that. What can you do to keep good control of your diabetes? So that's the process on the pathophysiology. Why you get diabetes is age, family history, our lifestyle, stress. We're getting rid of those beta cells that produce the insulin, and unfortunately, we're not able to regrow those cells. So once they're gone, and that's where the research is currently going to see, can we regenerate, can we regrow those cells? And right now we cannot. So once you lose them, your insulin is gone, then someone needs to start injecting insulin to be able to keep their sugar under control. So that I always like to show a visual so people can picture it, or what we mean with you're running out of insulin. This one talks about insulin resistance and your glucose. So our sugar goes in the blood when we eat food that turns into sugar, and our pancreas automatically releases insulin to try to keep those the sugar in balance. But the main role of this insulin is to open up the cells. We're talking about your muscle cells, brain cells. Is the key that will open up the cells so that sugar can get into the cell for energy. We need that glucose for energy. So if their insulin, if the insulin is not working well, and we got too much sugar going into the blood, then that's the key that is not working. So the sugar is going to stay in the blood, and it's going to travel to all the organs, causing damage to your eyes, your heart, your kidneys, your feet. Everything that gets damaged if that sugar is high for a long time, if we don't do anything to get rid of it, to put it in the cells for energy. And one of the symptoms people have is that they feel very tired because they cannot use this for energy. So we need to be able to change something or start treatment to help them get that sugar down. And that's where you start doing a finger stick to check to see how much is your blood sugar, so that we can increase the treatment if you're not under control. And it should be a regular visit every few months to the doctor. So how do you get diagnosed with diabetes? This is very important for everyone. Even if you don't have diabetes, if someone is here watching and they don't have diabetes, if you have the risk, you know it's in the family history, you really still need to work on it to prevent it. So this one here, there's 3 different ways they can diagnose you, and the first one is the fasting blood glucose. So if you go to the lab, I always recommend that you go fasting. So your sugar has to be less than 100 if you don't have the risk for diabetes, and if everything is still normal, you need to be under 100 fasting. So when you get a lab done, always get a copy of your labs and check to see. It's going to say glucose. Look and see what the number is. If it's between 100 and 125, you are in pre-diabetes if you're fasting. But if it's over 126 on 2 different occasions of the lab fasting, then you are already in type 2 diabetes. That's one of the tests. The other test is the oral glucose tolerance test. Women are more familiar with this because if they're in the pregnancy, everybody gets it done. And you basically come in fasting to the lab. The doctor may just order that to confirm if you have prediabetes or diabetes, because where the numbers are high but not high enough, so we're not sure, so we can order this test. So your sugar, when you go to the lab, they check it fasting, then they give you to drink 75 grams of glucose, and then they check you every 30 minutes for 2 hours. So we want to know that before the fasting, before you have the glucose, you are still under 140 fasting. If you're at 140 to 199, it's the pre-diabetes at 2 hours. If you are at 200 or higher at 2 hours, then that's diabetes. So this is the most accurate test to confirm if you have diabetes or pre-diabetes. And then of course we have the hemoglobin A1C. You probably heard about that. The hemoglobin A1C normal is less than 5.6 for people that don't have diabetes or they don't have the risk. But when they draw their blood, if the A1C comes back to between 5.7 and 6.4, that's pre-diabetes. And this is where you start making those changes again to get it back to normal. If it's 6.5 or higher, that's going to be a diagnosis of diabetes. And so it's important that you keep an eye on these labs, especially the A1C. What is the A1C? It's a blood test that you don't need to be fasting. If you go to the lab, they draw your blood, and then we're gonna go back 2 to 3 months on that blood and see how much sugar is attached to that hemoglobin, to the protein and the hemoglobin or your red cells. And so if you have a lot of sugar circulating in your blood, they're gonna see it attached to the red cell. So we're going back 2 to 3 months on your blood. That's why you don't need to be fasting. And if they'll give us a number, so you look at your labs when you get the results, and we're gonna get that number in a percentage. And it also is gonna give us an average of what your sugar has been for the past 2 to 3 months. So if someone has an A1C of 6.5%, that's the diagnosis of diabetes. That means their sugar has been running over 140 every day for the last 3 months. And when they have diabetes, the goal is to keep it under 7%. So once it reaches 7%, it's uncontrolled diabetes. And we need to do something to bring it back down below to between 6.5 and 7. But in average, someone has an A1C of 10.5, they're averaging about 255. So that means their sugar has been over 300 for the last 3 months. What we are seeing right now, because everyone being on lockdown and the COVID and the stress and eating and not exercising, our normal A1Cs average right now that we're seeing are 12, 13%. So people are coming in with sugars in the 400s, 500s. It's overwhelming for them to find out they have diabetes uncontrolled and we need to put them on insulin. And it's also overwhelming for us, the educators, that it seems like everyone needs to go on insulin right away, when before we have to start them on metformin, to start oral medication, lifestyle changes, and it takes time before they go to insulin. Right now, everyone is going on insulin. So it can be overwhelming for both sides, for you and for us. But what we're talking a little bit about the sensors, so I can show you how people with diabetes are rolling right now with the technology. But the A1C needs to be checked every 3 months. So if you have diabetes, the responsibility that you have to make sure it's done every 3 months if it's over 7%. If it's under 7%, that means you are doing good. Your diabetes is controlled, you're managing it well. And if it's very high, over 7%, it's every 3 months. Once it's under 7%, it's at least twice a year, every 6 months. So you want to make sure that it's been done when it needs to be done, because you could go a year without seeing a doctor, or the doctor forgets to order it and you are out of control in a year. So you need to keep an eye on that. It's super important. The first thing the doctors see and we see is, where is your A1C? How high is it? Because that's going to guide us to the treatment that you need to get right away. There are some factors here that can affect the result of the A1C. So I want to make sure that you are aware that this can cause high false positive high. So people that have severe anemia or liver disease or kidney failure can get a false high A1C. If you have like sickle cell anemia, I just saw a patient the other day that has thalassemia, and that's in their culture. So they're gonna have a false high A1C because of that. And certain medications like HIV medications, opioids, antibiotics, if you, obviously you don't have enough red cells when you have anemia or transfusion, early or late pregnancy. So we need to look at what's going on in the patient's medical history to see if that can cause the A1C to be high. So let the doctor know if any of these conditions apply to you, so that they cannot look at the A1C necessarily only. They can look at your blood glucose. You're actually having you do a finger stick and check, and then we get an idea what your sugar is running for sure. So the conditions for diabetes, there are different types of diabetes, and I'm not sure how many of you you know, But we have prediabetes, and that's before you get type 2 diabetes. So you have this period of time to change something and get it back to normal. And all it means is that your sugar is just over the normal, but it's not high enough to get a diagnosis. So there are no symptoms. You feel fine, right? But when you go to the lab, your sugar shows that you are at 100 or between 100 and 125. That's already prediabetes. If your sugar is over 140 after a meal consistently, then that's also prediabetes. So you have to keep an eye on those numbers. Obviously, the A1C of 5.7 to 6.4 is going to tell us you have prediabetes. You can change your lifestyle and make it go back to normal. Then this is the time that you can say that you got rid of it, that you put it back to normal. But then you know you have the risk, and it's going to go back to high if you change, if you stop making those lifestyle changes. We also have type 1 diabetes, which is, we're seeing more and more people with type 1 now, very, very high blood sugars. And this one is something that attacks the pancreas. It's autoimmune. We don't know what causes it, but we know it can be an environmental factor. It can be a virus. It can be the flu. It can be something that just triggers the patient's own defenses to attack themselves and attack the pancreas and shut it off. So they start producing insulin immediately. These people need to go on insulin right away. Oral medications are not going to help. Sometimes they do help a little bit at the beginning, but they're going to have to go on insulin. And this is the population, it's about 5% to 10% of the cases in the US. So not that high as type 2 diabetes. Most of the diagnoses for diabetes are type 2. So the type 1 is usually diagnosed in the hospital or at the doctor's office, and people show up with the symptoms. And these are the symptoms. They have frequent urination. They're drinking anything they can find, juice, soda, water, whatever they can find liquid. They just constantly are drinking and running to the bathroom, and they can have extreme weight loss without trying to lose weight. And you're losing weight fast, that's not a good thing. But their sugars are extremely high. They report feeling fatigued, or just don't have any energy because there is no insulin to help them get that sugar into the cells for energy. So they feel very tired. They're not able to function as well. So this one we can diagnose it quickly when they present to the doctor, to the hospital with very high blood sugars, usually. And I usually ask them, how much weight do you lose? And they'll say, oh, I lost 30 pounds in 30 days. And if they were obese or overweight, I say, okay, don't gain it back. Just keep it, see if you can keep it off. And then we have to start immediately the treatment with insulin and diabetes education. Very quickly, they have to change their lifestyle because they want to control their sugars. For type 2 diabetes, it's a little different. That means that you already, you had your sugars elevated, you got a diagnosis, but you can change your lifestyle. Your pancreas is still producing some insulin, so you're still able to control your sugar by changing your lifestyle, eating healthy, losing weight, taking oral medications, starting physical activity, but you can slowly progress to eventually someday needing insulin, or maybe not. But you can start controlling it better with lifestyle changes. You may have symptoms or you may not have any symptoms with type 2 diabetes. That's why it's so dangerous. It's one of the myths says it was mild. It's not. Diabetes is very dangerous. It's the toxicity in your blood, having the high blood sugar. You may have symptoms, you may not have any symptoms. So don't go by how you feel. You want to make sure you have that checked. There are other types of diabetes, and these are not very common. Gestational diabetes is during the pregnancy. They did not have diabetes before they got pregnant, and doesn't mean they're going to get diabetes after the pregnancy. So they may get the diagnosis only during the pregnancy, and then it goes away when they have the baby. But they do have the high risk for type 2 because they have the history of gestational diabetes during a pregnancy. So within 5 years, if they don't change that lifestyle, they could get to type 2 diabetes. The LADA is one that we're seeing more and more common. So the LADA is the latent autoimmune diabetes as an adult, because before they used to say that type 1 diabetes was autoimmune, it was a juvenile, that if you did not get diagnosed at an early age, you were not going to get type 1. So a lot of people got misdiagnosed with type 2 when they actually had type 1 because they got a diagnosis later in life, not when they were too young. So the late onset of is basically, as Lara is a patient that is under over 40s, 50s, 60s, and they get diagnosed with type 1 diabetes. They need insulin right away. And before we had that belief that you had to get it early to have type 1, so they got diagnosed with type 2. So these other ones are not very common, the MODI, but it's usually diagnosed before 25. And then we have the other one, cystic fibrosis and pancreatitis, that can cause the risk also for diabetes, and that glucocorticoids induced by high doses of steroids. We get people also diagnosed with diabetes that way. And then if a person has HIV or AIDS, also increases the risk for getting that diagnosis induced by that. So organ transplants also. So those are not as common, so the doctors may not be as familiar with it, but they're there. And we're seeing people coming in induced by steroids when they get an injection for back pain or knee pain. So we let them know that it's due to the high doses of steroids, and we need to start them on something to help them bring down their sugar. So everyone is different. With diabetes, just make sure you know that everyone is different, it's individualized. The treatment is different for everyone. It's not gonna be the same. We get all the time that, oh, my mother used this and it worked for her. Yeah, but that was your mother and she was in a different stage of diabetes. If you're just starting, then this is what you need to do. So it's not gonna be the same for everyone. We do know that high blood glucose is very toxic, and that's why it's not good, because it's damaging all the organs and the vessels, and it's traveling in the blood head to toe. So if you have high cholesterol and high blood pressures, perfect ingredients with high blood sugar to build this plaque and prevent the blood from flowing freely, getting slowed down and causing that blood clot. So that is not good. So you want to make sure that you start noticing damage if you get neuropathy, that the nerves on the feet, you start losing sensation, it's painful, you have cold feet. So this is something that needs to be checked for complications that come from long-term from having that high blood sugar. And in the LGBT community, there is not, unfortunately, that much information about that. What we find is that the risk for the LGBT community is because they smoke more, 38 to 59%, and the gay community smoke more than other heterosexual people. So it increases their insulin resistance. And then for women that are lesbians, it's higher risk, 38% more can develop polycystic ovarian syndrome, and that causes insulin resistance also. So that's 38% of lesbian women, then 14% on heterosexual women. So obesity, insulin resistance, with PCOS, that they have polycystic ovarian syndrome, it's hard to get pregnant, it's hard to lose weight. So we want to start on metformin right away with them and help with weight loss and preventing diabetes, because it's a high risk. African Americans, the LGBT community is higher risk also in adults. And then the rate is 4 times higher with HIV, if the gay community has HIV. Some medications that our patients have, if they have HIV medications, these ones can cause the high risk for uncontrolled diabetes also. So we look at what are you taking. So we know, okay, we need to increase the treatment because you are taking these medications that are going to increase your sugar more. So we want to make sure that if someone doesn't have insurance, also is going to affect their diabetes management. So we need to look at all the resources in the community, getting people educated. So we also have the aging community and the LGBT community. There is less information, especially for transsexuals. Right now that we're seeing more and more. So the LGB is a little bit there. There are a couple of books that I ordered that are the only ones available now. I remember when I did my bachelor's degree in nursing, one of my papers was is when I just moved to Palm Springs. It was I wanted to do. I was so I don't know, not used to being in Palm Springs, and I did a paper on the gay community in Palm Springs, and I was surprised that I could not find any information about that. But my teacher was very impressed when I turned in my paper. Like he was like, "Wow." So I found out that more than 50% of the gay community in Palm Springs were male. I'm like, oh, okay. So I learned a lot doing that research. That was years ago. But for lesbian women too, they live with a partner or they live alone. All of this, the lack of support in their family, if they live alone, if they don't have any children, um, affects everything in diabetes management, cardiovascular, physical, mental, the stress, physiological, psychological stress for diabetes. And we see that in our patients when they come in. I notice we get a lot of people in the LGBT community with diabetes, and getting them to start insulin is always something different for everyone. But a lot of people accept it right away. Others are like, I'm not going on insulin. They don't even want to come back and see us. And it's for us to help them get us under control and understand why it's important that if they need insulin, they start injecting right away. So diabetes management is all in the control of the person with diabetes. We are here to help and support and guide through it and make sure that everything is controlled, but it's 99% is all in your hands. Not on your doctors, not on us, is that you, the person with diabetes, had to make the changes. So you have to understand the process of the carbohydrates, the stress medications, all the things that have to be put together to help you with diabetes management. And hopefully you have a good diabetes educator that understands you, that is willing to help without judging. I'm not sure if someone is trying to say something, but I'll open up for questions in a second. So you want to be making sure that you take control of it. And why? Because you need to prevent the long-term complications. When someone goes blind or they lose the leg or their kidneys fail or they had a heart attack, all of those can be prevented. The key is controlling their blood glucose. So if you keep that sugar in good tight control, then you probably will never have any of those problems. Those that we see that had complications is probably mostly because of lack of education. They've never seen a diabetes educator, they've never seen a dietitian. They don't know what to do. No one has really been able to help them. So right now, diabetes is out of control because of the COVID. Most of our patients on the COVID units have diabetes. It's very sad and at any age, but also COVID is attacking the pancreas. So people are coming in with the virus, but they didn't know they have diabetes and their sugars are very high. So they leave the hospital with a diagnosis of diabetes and they need insulin because their sugars are very high. So we're seeing that in younger people now. I saw a couple of patients on the COVID unit in the late 20s and early 30s, new diagnosis of diabetes. So that is important to understand, that to get it in control right away is the key. So how do you manage diabetes? What do you need to do? One of the first things we ask is you need to check your sugar. You need to do a finger stick, right? And people don't want to poke their fingers all the time. So the good thing now is that we have the sensors. They're called CGMs, so continuous glucose monitors. These are very popular right now in the diabetes, and they're extremely helpful because you don't have to poke your fingers so many times a day, especially if you are injecting insulin. You apply the sensor to the back of the arm, and then you either scan with a reader to look at your sugar, or you can download the app for the Freestyle Libre, and then you scan with the cell phone. So it will give you what your sugar is, and it also shows you that arrow, what direction that sugar is going. If it's going up, is it going sideways steady, or is it going down? So you are able to see what's happening to your sugar throughout the day. As you need to scan at least every 8 hours to be able to see all that information for 8 hours. So we have our patients, everyone is going on the sensor, And we have them scanning before each meal, 2 hours after the meals, and at bedtime, so that it can give us a lot of good information about what's going on. So the sensors are very popular. Everyone is going on them. The other one is the Dexcom. The Dexcom is inserted on the abdominal area, and then apply the little transmitter on it. And that sends your sugar directly to the cell phone or to the receiver. Or if you have the Apple Watch, it's transmitting your sugar directly to those devices every 5 minutes. So you don't have to do anything. You just have to apply it and change it every 10 days. The Freestyle Libre is every 14 days. And what is really nice right now for the CGM and the hospitals, because of the pandemic, they approved to use the sensors, the Freestyle Libre, both of them, but we're using the Freestyle Libre in our COVID patients. So what happens is I go in the COVID units, I have the patients insert the sensors on the back of the arm with their smartphone. So they download the app, they scan, then we download an app on the iPad, and the nurses, they don't have to go in the room every time to check the patients exposing themselves to that virus and then using the PPE. So when the patient scans, they want to share that information with us. So we see their sugars that in the iPad at the nurse's station. So that is helping us preserve the PPE that we have in case we have another surge, hopefully not. And then also for the nurses to not be as exposed to this virus as much. So it's, we're started to, I tried it a couple, last week, couple of patients on each unit, and we're rolling it out next week. So all the nurses are getting trained right now so they can help me with the patients. The patients can do it themselves. We just have to walk them through it. And they love it. They are new diagnosed with diabetes here, and they leave with the sensor on, and they just scan themselves, and they love that. They don't have to poke the finger. So this really makes a big change right when you're new diagnosed with diabetes. So like, oh, this is what I can do. I don't have to poke my finger so many times a day. When they inject the insulin, they just scan themselves. So this is working really well. The Dexcom, people use it also because this one communicates directly with the insulin pump. And so it's transmitting their sugars to the pump. It tells the pump when their sugars are going down, so the pump stops giving insulin. If their sugar is going up high, and it gives them a dose of insulin. So the sensor and the pump together, working together, are making it a lot easier for patients. Less work that they have to do, but it's not completely going to manage their diabetes by themselves. The patient still has to add the carbohydrates and change their lifestyle a little bit and watch what they're doing. So why checking? What do we need to look at? If you have diabetes, we go by the American Diabetes Association guidelines. So before a meal, sugar has to be between 80 and 130 before you eat if you already have diabetes. If you remember from the previous slides, if you don't have diabetes or you have pre-diabetes, you have to be less than 100, always. And so if you are a diabetes now, 80 to 130 is good. We relax the guidelines a little bit so you have more room to play with those numbers. And then if you check 2 hours after the meal, it should stay below 180. So you need to, that helps you to see, what did I eat? How much did I eat? Was my meal balanced? Why did I go so high? And it also helps you keep an eye on the A1C. How high is it going to be? If you're high all the time, then the A1C is going to be very high when you go to the lab. So it really helps you make some changes by keeping an eye on your blood sugar. I wanted to say here, the ACE is the American Association of College Endocrinology. So if they refer you to an endocrinologist, they have more strict control on your diabetes. So their parameters are a little more strict. So you will have, that's why they start you on medications like insulin or other medications and more aggressive treatment, because they do want to help you prevent complications. So they'll have more strict control on that. And the other ones, we don't see them as much, but for pregnancy, they're also very strict parameters if they get gestational diabetes. So we need to keep an eye on the numbers. So what can you do? Take medications. Right away, we start you on metformin, low dose, once a day, twice a day. And then it helps you with the fasting glucose. So every time when you get up in the morning, then you see if that medication is helping, or we increase the dose, or do we need to add another oral medication? So it takes a while before we get you to insulin if you are going to need insulin. But medications are very important. we have new medications now that are also have a lot of good studies that help with cardiovascular. They had a really good benefit on the cardiovascular. And so the cardiologists are also putting patients on these diabetes medications. And so you can take some of the newer medications before we go on insulin, or you can take insulin also at the same time with all these other medications. So we want to make sure that you have the right medications, the right dose, that your sugar is staying within control. And if you are taking any of this, you may notice or recognize these ones, Farxiga, Jardiance, are the most popular ones. They make you, when you start this medication, they make you pee a lot. So you want to drink more water. It also is, what they do is that you are peeing out sugar, because instead of getting reabsorbed in your kidneys, it makes you pee out. So that sugar comes out instead of getting reabsorbed. So your sugar gets controlled better. They also help with weight loss. So that's why they're more popular now. And the GLP-1s are the injectables. So you probably heard about Ozempic, Trulicity. I see commercials all the time on TV. Those are injected once a week. Victoza is injected once a day, but all the other ones are injected once a week. And those help you with suppressing the appetite. So you're not as hungry, you're not eating as much, your sugar gets controlled quick, and also help with the weight loss. So these are really good medications. Again, for cardiovascular benefit, these are a good choice to have if your insurance covers them. We are putting a lot of people on this medication. And then obviously physical activity is important. Recommended is 30 minutes, at least 150 minutes of physical activity a week. You can break it out and split it out however you want, as long as you get those 150 minutes. And insulin, if you need insulin, don't be afraid of it. All it means is that your pancreas is not producing it, so you just want to inject it because you need it. You need to get your sugar under control. And people are afraid of it. They have the myth that insulin is bad for them, that it's going to cause them a complication. And people end up with complications because they haven't injected insulin early enough during the beginning of the disease, or when they need it, when their sugar was high. So they are refusing insulin, and that's how they end up going on complications. Insulin is very easy to inject these days with the insulin pens. The problem is that it's very expensive. So if insurances don't cover it, to get it is very difficult. But at Walmart, they do have an insulin that is 5 pens for $43. And you don't even need a prescription to get it. So we prefer that you get a prescription so that you know how much to inject. But that's all people can afford right now, then it's better than nothing. So we recommend that they get at least that one. And on the food, we're gonna go quick on the food because I know it's very important for people with diabetes, for all of us to eat healthy and really watch what we're eating. So carbohydrates are very important to understand what they are, how they work. These are good nutrients that we need in our diet, so we cannot skip them or stop eating them. But you do want to look, if you have diabetes, on your carbohydrates or pre-diabetes. What are carbohydrates and how they affect your sugar? Proteins, fats, and vegetables are part of the healthy balanced meal. So we need to make sure that that you know that when people come to us and say that they don't need any more sugar, I know they're eating sugar because that's our source of energy. So that's why we need these foods. All of these are sugar, right? It's maybe not eating as much big portions that will affect your sugar, but you can have a little bit of that. And that's where we want to teach you when you see the dietitian on how can you eat all those things, but at the same time keeping your diabetes under good control. All this other stuff are just sweets and foods that are not that nutritious, but people still like them, people still eat them. And if you have diabetes, one of the myths was that people with diabetes cannot eat any sugar, which is not true. You can still eat it. We just need to keep an eye on your sugar. How often are you eating this? How much, right? What is happening with the A1C so that we can help you adjust your diet, and also what are you drinking? If it's regular soda, it's really bad for diabetes because it's all sugar. This is how fast it converts into sugar on the carbohydrates. So it goes straight up and comes down. it leaves you with no energy, and then you're hungry again quickly. So you always want to be eating when you have diabetes. The protein is important because it will slow down. It will just break it down into sugar. It takes a little longer. And then fat. So fat will take a lot longer to break these carbohydrates into sugar very slowly, so that they don't peak after the meal, or you don't get affected and ended up injecting more insulin. So the key here is mindful eating. What are you eating? What are the foods that you like? And this is where you want to see the dietitian to work with you on a meal plan about the foods that you like to eat, not what we want you to eat, because you're not going to make it if we tell you you just need to eat this and that. Then it doesn't last long, because you're eating things that we're telling you to eat, not what you like. So it's important to work with the dietitian closely and come up with a meal plan of what you like to eat. And ask these questions to: how often do you, are you too generous on the meals? How are you eating out all the time? Because those are big portions. And how many times do you cook at home? Do you measure servings? Do you read the labels? Those are important questions to: how can I change my eating habits? Do I need to make any changes? And then this is portions. So this is what the portions were back in the 50s, but now they're extremely bigger. So the portions are getting bigger over the years, so people are getting bigger, right? They also, I saw something about fast food, about the suicide burger. So, or the Sky Mile High burger, things like that. So the exaggerating everything right now. And for diabetes, once in a while, if you want to eat these things, it's fine. You cannot eliminate them completely, but you really want to watch how often you're eating that. So for men and women, if you have diabetes, if you want to lose weight, men are allowed, or it's recommended, that you get about 3 to 4 carbohydrate choices, which will be about 45 to 60 grams at each meal. So 3 times a day, if you can keep it between that range. And if you want to maintain the weight, then you can also eat about 4 to 5 choices, a little more. Women, there's a little less carbohydrate that is recommended, about 2 to 3 carb choices for about 30-45 grams at each meal. If maintaining it is 3 to 4 choices. And also based on breakfast, lunch, and dinner, about less than 200 grams of carbohydrate a day. But you cannot eat them all at once, so you want to split them up throughout the day with the meals and a snack if you need a snack. But if you eat them all at once, obviously your sugar is going to be very high if you check. So you want to get this little portion from the carbohydrates, because those are the ones that will turn into glucose. And that's why you're checking your blood glucose either before the meal or 2 hours after the meal to see how they affect you. The other thing important is the labels. How are you reading the label? What are you looking at? The main thing we look at is the serving size and how much total carbohydrate is in that size, the grams. Are those staying within the allowance that I have for the meal? It's very easy. You can be over 100 grams in one meal if you're not watching that serving portion. The labels are usually per serving. So you wanna, if you double the portion, you double the label. So you wanna keep an eye on the carbs. Carbohydrate counting is very important with people with diabetes, especially they need to dose insulin for that. They need to know what they're eating on carbohydrates, because they need to cover with insulin. So the plate method is an easy way of balancing the meals to see, did I eat enough? Was it a big portion? Did I have enough carbohydrates? Or am I taking the carbohydrates out and just eating protein and fat, bacon, eggs? But you also need that carb for energy, so don't completely eliminate them if you don't have to, because you don't last long with that lifestyle change. Because we know that we all like carbohydrates. We just need to eat them in smaller portions if we have diabetes. So balancing the plate is important, and I'm going to show you this one. This one is very colorful from the ABA. These ones here are the ones that turn into sugar. Potatoes, corns, all the fruits, all the dairies, grains, beans, all of this you're allowed to eat them. It's just, again, watch the amount, because we want the half of the plate to be the non-starchy veggies. So a little bit of carb on those. about half of the plate to make it that, and then the other half to make a little bit of protein. We don't need that much protein, but we need some, and then a little bit of carbohydrate. And this is where you, when you eat these foods, you want to ask yourself, I'm asking my pancreas for insulin every time I eat these foods. So then you want to make sure that you know exactly how much you're having, and maybe decrease the amount a little bit, but you're still having those foods. This is your sugar, is your energy. So it is hard to stop eating carbs, eliminating them. A lot of people can, but it's very hard to do that. And for diabetes, we just have them count their carbs so they can dose their medications based on that, and make sure that they're eating more vegetables and more the non-starchy vegetables, and a little bit of protein, because also need to look at the amount of protein, because it's higher in fat and calories. So this is a really good visual of how you can balance your plate and the portions. And we're talking about a 9-inch plate. So it's not restricting, it's not us, the educators or the dietitians, telling you that you cannot eat this or you cannot eat that. And this is coming to an end, but I'll say that having a healthy diet, balance, just changing that, your sugar gets controlled very fast. You see the results very quickly. Breakfast is the big one. People that eat a bowl of cereal and milk and all that stuff, and they add more vegetable fruits to the cereal. That's when they are always high right from the starting their day with that breakfast high in carbohydrate. So once they balance it, they're like, oh, their sugars get controlled very quickly. So we never tell you to stop eating certain foods. I know the doctors tell you, don't eat whites, don't eat this, don't eat that. And it's not necessarily, it's just to learn how you are eating them so that they don't affect your sugar. But it is important to take control of your diabetes, and don't let diabetes control you, because you are in charge. You're the one guiding this to where are you going with it, and keeping an eye on it. And I know it's a lot of work and it's tiring to do all this, but you have to do it because you are the only person that can do this to prevent any problems. You could have a normal life. You just have to keep an eye on the sugar. That's the only thing that, I gotta make diabetes part of my life. You cannot leave it at home when you go on vacation. You did not ask for it, but you got it. So you gotta include it as part of your lifestyle to always include that diabetes, because that's when you start forgetting about it or you start kind of getting too comfortable with it, then boom, it gets out of control again, and it's harder to manage it after that. At Eisenhower, we have the diabetes education department. We're recognized by the American Diabetes Association for diabetes self-management. And we also have the diabetes prevention program for those with prediabetes. That program is recognized by the CDC, and that's a 12-month weight loss program that we need to put everyone with prediabetes to prevent type 2 diabetes. And you have to qualify for that, so I'll show you in a second. But all our educators are board certified in diabetes education. The ones that are now that are new are working on their hours to apply for the boards. So it's a requirement that they get certified. So dietitians also. So we're specialized in diabetes management and diabetes education. And so you want to see those dietitians that are dealing with diabetes. And we do have support group for type 1s. It's virtual right now in Zoom once a month. And then we have a free class once a month open to the community on the first Monday of the month from 3 to 4. It's virtual also right now until we are able to meet in person again. For those that need help, and if they don't have insurance, you're not covered or whatever reason, there's no excuse to not get help when you're trying to manage your diabetes. To qualify for the diabetes prevention program, Medicare covers that, but you have to be over 18. You have to have a BMI of 25 or higher. If you're Asian, it has to be 23 or higher. A1C needs to be between 5.7 or 6.4. So you need to have the BMI and an A1C or the fasting glucose between this range. The other ones, you don't have to have all of them, but you need to have the weight and one of the labs within the 12 months on that range to be able to do that 12-month program. So the doctors can refer you or you can self-refer to it. It's just that right now, because of the COVID, we don't know when we're gonna start in this group. So we have a lot of people waiting to get in to that one until we get the green light from Medicare to start again. Then we'll call everybody again to get started and prevent type 2 diabetes. I think I cover all the myths here. The diabetes, you can eat sugar, obviously, because we need it. Diabetes is very dangerous. It's not mild. It can cause a lot of problems. It doesn't affect only overweight or obese people. It affects everyone. You can get diabetes at any age, any time. Doesn't matter who you are. Anyone can get diabetes. You can go blind and lose a limb. Yeah, if you don't take good care of diabetes, but not everyone with diabetes has those complications, right? And then dangerous drivers. I think that what it means is that if your sugar gets too low, you can pass out driving. So you are a danger to yourself and to others, like a person that is a drunk driver. So the police are trained to catch people with diabetes that are going in hypoglycemia and they get too low to give them sugar, but you can lose your license. So I think we're all dangerous drivers, not just people with diabetes. And then the last one here is what can you do? First, get the diagnosis, understand it, accept it quickly so that you can start the treatment. Eat a balanced meal, healthy balanced meal, exercise, get physically active at least 150 minutes a week, and you split it however you want. And understand the medications, how they work, what they do, take them. They only work if you take them, right? And then cope with the disease, the diagnosis. If you're having a hard time with it, ask for help. Manage your stress, control your stress, work on the stress management, especially right now, because that's affecting your sugar also and your weight and everything. And then use a meter or a sensor. If you need to check your sugar, you need to use those to see where you're going with it. What's happening? Is the treatment working or is it not working? Do I need to change something? Do I need to go to my doctor sooner than later? And you can manage diabetes. We see people do it all the time. They get control quickly. They maybe get them off insulin. Not true also that if you start insulin, you cannot get off of it. Many people do. And so you can manage diabetes, have a healthy, happy life, and just become good friends with it. And you are in control. And I think that's it. I don't know that we have any time for questions.
We do have a couple, and this is Brett. I have two questions that came.
So fast because I had all that information that I wanted.
I know, no worries.
Yeah.
The first one goes back to Mark, who was asking, I just started using a Libra CGM, but didn't get much education. What target range do you recommend?
For the CGM, for diabetes, is 80 to 180. If you set it up on your app, you want to set it to 80 to 180.
Great, thank you.
Yeah, the range before your meals, when you scan, it has to be 80 to 130.
Okay. And another question for Marcus was, when you say after a meal, is that 1 hour or 2?
It's 2 hours from the first bite. So the minute you have that first bite, you look at your clock or your watch, and 2 hours after that, you check it, because that's at the peak. After the 2 hours, it will go down to normal again. So you don't want to check an hour after or 3 hours later. It has to be at the 2 hours from the first bite.
Great, thank you. Okay, others have questions?
If you have questions, unmute yourself.
Yep.
Unmute yourself. Mute. Hello?
Hello, who's this?
Hi, this is Joan Parker. How you doing?
Oh, hi, Joan.
Hi, how's it going? Hey, thanks for these classes. Are great.
Yeah.
Question on, you said take your meds. If you don't take them, they don't effective. I think I spoke to you about this. I'm pre-diabetic, or not pre, what do you call it? Type 2, which I'm still in denial about. But anyway, I'm doing everything. I've been testing the blood. I've done it like 9 times. The highest I've been is 130. What I want to know is about that Ozempic stuff, because what really entices me is the suppression of appetite and weight loss, which I really want to do. I mean, I've lost some weight, but not enough. I mean, I'm getting there. It's slow, but I'm thinking, should I entertain that? I mean, I do have a script for it, but I just never filled it out because I was trying to get rid of this thing without taking all this meds and stuff.
Oh, that's why you say that they work if you take them, right? So you have the prescription, but you haven't filled the prescription yet for the...
Right, because I talked to my doctor about it and said, well, I want to, see if I can get rid of this thing so I don't have to start taking drugs and all this stuff, because I'm being told once you start doing this, it's going to make it worse and it's going to turn type 2 into type 1. And And if you start doing all these drugs, you know, the first they said Metformin, and then said, no, I can put you on Ozempic because that helps with the suppression of the weight and all that. Meanwhile, back at the ranch, like I said, I'm doing any drugs. I'm just doing it cold turkey. I stopped eating all sugar, you know, like what I went crazy on.
That's what I was saying, John, that you cannot really completely stop eating sugar.
Well, I mean, your food, like, you know, like strawberries, raspberries, you know, that turns into sugar.
Yeah, but that medication, Ozempic, is a good medication to take. It's once a week. But the reason they're giving it more now is because of the cardiovascular benefit, which is one of the high risk when you have diabetes. You have 2 to 4 times higher risk for a heart attack and a stroke. Having diabetes.
Yeah.
So that one is a really good medication. The thing is, can you tolerate the medication? Because it's given weekly. One of the possible side effects is nausea, but it does help you at the beginning, and then it gets better. It helps you to feel full longer, so you're not as hungry, you're not eating all the time. Your sugar gets controlled, and then you lose weight at the same time. So that's why they're good too, and everybody is using them now. The coverage is the key of your insurance, because those can be very expensive when they're brand new. But yeah, I will say try it. The only way to know is if you try it.
Well, what I was asking was, do I need to try it if my blood levels, you know, before I eat anything, or, you know, the highest? I've done it 9 times, and the highest was 130, but like today was 126. The week. Couple days was 121, 107.
It will help you. It will help you get your sugars more under control. Are you diagnosed with diabetes, you said?
Type 2.
Yeah, so it will help you get your sugars down, and with the weight loss if you need to lose weight. But we don't promote them as weight loss. It's the diabetes injectable medication.
Okay. What is, can you say one more time, when you're before pre-diabetic, what is your normal blood supposed to be again?
For For pre-diabetes?
Let's say you poke your finger to just look to see what's the normal blood thingy before?
Okay, so for pre-diabetes, less than 100 fasting. For
less than 100.
For diabetes, 80 to 130.
Okay, 80. Ooh. So is what?
So you want to look at the fasting first, because that's the reason they are putting you on those medications, to try to help you get that fasting to normal.
Well, less pre is less than 100. What was the next one? 80 to 130. What's that one?
That's the diabetes range for before meals, for fasting or before meals.
For that's type 2?
Type 2 or any type of diabetes.
Oh, any type is 80 to 130.
Yeah.
Oh, bummer.
Does anyone else have any questions? We want to make sure we answer everyone's question.
Yeah.
Thank you.
Thanks, John.
Thank you.
Okay. I don't
Anyone else?
Any more questions?
Oh, Gail. Gail's talking, but you're on mute. Hold on, Gail. I see your lips. Hold on, Gail.
You need to unmute, Gail.
Gail, I'm trying to unmute you. I'm asking to unmute you.
Can you click on the microphone, Gail? On the little microphone? So that we can hear you.
There you go. Oh, you just had it.
Click again. There.
No, I was just saying thank you. I'm good.
Oh, okay. We thought you had a question.
Okay.
Anyone else had a question?
How do you get into a program or an appointment with you?
You just ask your doctor for a referral. And so if your insurance covers you to come in, we'll just get a referral and we call you to schedule an appointment.
Okay, very good. Thank you very much.
Oh, you're
good
welcome.
Information.
Thank you.
All right, Candace.
Everyone's good?
Anyone else?
All right then. Thank you, everybody. If there's no more questions, it doesn't look like it. Obviously, this was a great topic and very informative. So thank you very much for all that all the knowledge that you imparted on our community tonight.
Yeah, thank you. It's a lot of information for 1 hour. We normally give it like a long process.
It was a lot. Yeah.
So that it sticks, because it's a lot of information.
And our next lecture will be, with the center, will be August 26th, and it's Dr. Thrasher, and you'll be speaking on opiates, the good, the bad, and the ugly.